Good afternoon to everyone. So now we are entering into the next session. Now in this two invited lectures are there. I now request Dr. V. Radha, CSIR Emeritus Scientist, CCMB, to act as a chairman for this session. Now I request Professor Geeta Vemuganti, Dean, School of Medical Sciences, University of Hyderabad, to come onto the dais.
Good afternoon and welcome back to this post-lunch session. In this session we have two talks, one by Professor Geeta Vemuganti and the other by Dr. Sangeeta Mukhopadhyay. I'll give a brief on Geeta. I think in this audience most of you know about her contributions. Geeta presently heads the Medical Sciences Unit at the University of Hyderabad and she's been there since December 2010. And prior to that, she was with the L.V. Prasad Institute, head of ophthalmic pathology. And over several decades, I should say, she has contributed extensively to bringing work at the bench to the bedside, particularly with respect to eye diseases. Her current research focuses on cancer stem cells in retinoblastoma using new animal models, and she's also looking at the role of stem cells in leprosy and human lacrimal gland cultures. She holds several honorary positions, and she has actually had advanced training in ocular pathology at the Doheny Eye Institute, Los Angeles, and has been a visiting pathologist at the Eye and Ear Infirmary and Department of Pathology, University of Illinois, Chicago. She has published extensively and been instrumental, one of the first in India to establish in vitro cultures that have helped treat a large number of patients with eye problems. She's a recipient of several awards and honors, and she's the fellow of the Association of Research in Vision and Ophthalmology, and also a member of the Technical Advisory Group, Medical and Health and Pharmaceutical Sciences. She's a member of the ICMR expert group on stem cell research, and been an elected fellow of the Telangana Academy of Sciences. Without taking too much time, I invite Geeta to give her talk on stem cell research and applications, lessons from ophthalmology.
Thank you very much, Radha. And I wanted to profusely thank the organizing team for giving us the honor of sharing the dais with such luminaries. And I think celebrating our work is one thing, celebrating with like-minded people is another thing. And the work itself has been very rewarding for me. To get honors is like bonus. So with that, I would share my experience. I think many times we don't get to share the last slide. So I think we seldom get to celebrate this slide. This is my mini infantry, I call it. All the students who have taught me different things, different tools of work, and my colleague, Virendra Sangwan, I call him a daredevil surgeon, without whom I wouldn't have been successful in this journey. And all my colleagues, so right from limbus to conjunctiva, oral mucosa, lacrimal glands, cancer stem cells. These colleagues have been my partners in this work. And all my students, Sagar did the cancer stem cell work, he did the oral mucosa, and Anis and Shubha did the lacrimal gland work, and so on. Rohini does the cancer stem cell, these two do the cancer stem cell work, and these are my collaborators on the UKD grant. And in fact, the work started with one of the colleagues from CCMB, Shashi Singh, and all the colleagues here. So with thanks to all the granting agencies and everyone, I would now go ahead with presenting my work. I think I'm missing the stretch. Yeah. So if we are talking about stem cells, it may look a very basic definition to most of you, but it's important to start from a very simple known to unknown. As a teacher we call, we emphasize go from known to unknown. And this is something we are all familiar with, the hierarchy of stem cells, right from totipotent to adult stem cells. As the stem cells become more mature or adult type, the differentiation towards different lineages also goes down. But the property of being undifferentiated, capable of self-renewal remains all through. Even property of differentiation remains intact. However, the type of differentiation which occurs in different types of stem cells goes down from embryonic to adult stem cells. The challenge lies in identifying these cells. There's another important thing that we are now learning. So in addition to learning about stem cells, we need to learn about the microenvironment of stem cells, and that is the niche. They are equally important and they influence the work that is being done by the stem cells. So does it mean that if we know adequately about the cells, cell culture techniques, the stem cells, and so are we ready to do the cell replacement and tissue replacement? So like the hierarchy of an organization of the body is from cells, tissue, organ, systems. So when we talk about cell or tissue replacement, we need to answer to ourselves, are we looking at one-layered epithelium, stratified epithelium? Are we looking at the stroma? Are we looking at a 3D structure? Because the entire body is a 3D structure. So and the tissue engineering. So all this depends on what area of stem cells are you working on. So we started this journey. It's maybe because the slides are heavy, I would just go ahead with it. No, it's going ahead. It's going very slow. Yeah. This is the one, right? This one.
Not this one. This one blank. This one next slide.
So if we have to follow the stem cells, the best way is to follow how an organ was created or the entire human being. So in the field of eye, it starts from 4 weeks and it continues to birth, and even post birth there are certain modifications which have to be done. So all the different layers of the eye come from different tissues, that ectoderm, endoderm and mesoderm. So therefore we cannot say which layer will come in one particular fashion. So we looked at these, I think the slides are a little heavy, so can you start doing from here? It's not, yeah. So the ocular surface, we are all seeing each other because of this transparent cornea that we are, the black part of the eye actually is the transparent cornea which is responsible for the vision, and the white part is the conjunctiva. So this is the line of, today we talked about the missiles. So if we don't have this line of control in active with intact stem cells, what will happen is the good neighbor, the conjunctiva, will come into the cornea. Cornea is avascular, so therefore cannot sustain the stemness within its body. It stores the stem cells at the periphery of the cornea called as the limbus. So that is the fundamental principle based on which we have this stem cell therapy. So what happens if that limbus is damaged? If that limbus is damaged, this is what happens. The good neighbor comes onto the cornea and along with it will bring the vascularity, the fibrosis, which is not good for the transparent cornea because we will not be able to see. So the surgical principles dictate that if any tissue is damaged, you have to replace it by the same tissue. So from the good eye, you have to take few clock hours of tissue and replace the tissue from the bad eye. But this means that the patient's eye is already damaged and you are going and fidgeting with the good eye. This led to Grezzilia Pellegrini starting some work on limbal stem cells. So we were not the first ones. We followed the group by Pellegrini, but however they had used feeder cells. The techniques were different and we did some indigenous ways. So the principle is, instead of taking few clock hours of tissue, can you take 2 millimeters of tissue, because they have stem cells, they'll be able to regenerate, make it into a sheet of epithelium and transplant to the patient after surgical debridement. So this was the strategy, very simple strategy of taking a human amniotic membrane and initially we started with feeder cells, but subsequently we stopped using the feeder cells and we watched these cells grow into a sheet of epithelium based on the principle that it has stem cells. So instead of using the culture insert which was being used by Resai, we designed a natural way. In fact, being a pathologist, I use glass slides very often, and I said, why look anywhere else? Let me go to my own glass slide. And I made 3 bits of one glass slide and tucked the amniotic membrane as you would tuck the baby at bedtime. And we denuded the amniotic membrane and we used this instead of the culture insert that was published earlier. So these are the array of tests that we did. Basically, by definition, it should have stem cells, transient amplifying cells and differentiated cells in the culture. So we used an array of all the markers to prove that the cells which are in the cultures are a mix of both stem cells, differentiated cells as well as transient amplifying cells. So it took 1.5 years for us to standardize this technique, and my colleague Virendra Sangmon was getting restless. He says, tell me, when can we start? The thing is, just like the switch, are we ready to do that switch? So it took us one fine morning to decide, yes, we are ready. It took us 14 days to culture, and 14 to 21 days is the time we decided that we are ready for transplanting it. And then, so what we did, which was published in Nature Protocol, is 2 millimeters of the tissue, take it in the transport media, use the amniotic membrane in the dish that I explained to you, and we use the explant culture. As you may be familiar, it can be both suspended or explant culture. I prefer the explant culture because, being a morphologist, I would like to see the cells grow, and we saw these cells growing on sheet of epithelium on the amniotic membrane, and they made a stratified epithelium. So should we wait for stratification to occur outside, or should we go for in situ stratification? And that's when we decided that we would probably go for in situ stratification more. So NIH gives us this guideline to go to check whether you are ready for cell transplantation. All the regulatory approvals, do you have the sufficient quantities of the cells that you desire? And are they differentiated? Will they survive? Will they network, integrate, cause no harm to the patient, most importantly, and will show functions? So that's the reason why I think this is one of the good models. I apologize if someone finds it repulsive. This is a victim of a holy accident where both eyes were damaged because by a child who unintentionally threw some acid. So if we have to do, this patient has hardly any good limbus left. So we harvested 2 millimeters of good limbus from one eye and treated both eyes. And the patient was seeing, though there is some scarring still, but the patient was happy with the effect, and we could do this for most of our patients. However, when other groups did this work, nobody talked about the extent of the damage that we see in India. Unfortunately, the chemical burns, the alkalis, the tuna, which is the biggest culprit, goes through and through, penetrates the layers of the eye. So nobody talked about the conjunctiva being damaged, the lids being damaged. So how do you treat such bizarre and advanced cases of chemical burns? So my colleague Virendra wanted a conjunctiva at the periphery. He says, you know, limbus you have given me, corneal epithelium is fine, but I have to transplant conjunctiva because this is severe symblepharon and any raw wound will stick together. So to treat these patients, what we did was again go back to the nature. The limbus is circular in structure, so I designed a ring barrier made of perspex, which was one of the material which I used to use to make my specimen mounts. And we tried everything right from children's bands to bottles and glasses, but finally I settled down to the perspex, which had the best finish. So when I kept this ring barrier With the limbal in the center, conjunctiva at the periphery, I had two types of epithelium on one membrane, exactly similar to what nature is. And this is something that Virendra was very happy about, because without using a separate conjunctival epithelium, he could use one membrane to treat both parts of the eye. So basically, to summarize, what did we do? We took the good limbus, made it into sheet of epithelium, transplanted it after surgical debridement, and if the deepest stroma is clear, the patient doesn't require any other treatment, which happened in about 40 to 50% of cases. But in about 30% of the cases, the deeper scar is still there. So the patient now has to undergo a corneal transplantation like this. So the reason why I call it a model for cell therapy is, even after the bone marrow transplantation, which is one of the most successful cell transplantations, we cannot have access to bone marrow. We evaluate success of bone marrow transplantation by the function. That means the bone marrow cells have regenerated. Here we had access to the tissue which received the stem cells, and that's why all the criteria, whether it survived, networked, integrated, resolved, contributed to the function and caused no harm to the patient. Every criteria was met with in this small model of ocular surface regeneration. Do we have proof of survival? Yes, we had clinical survival. As you can see, the Kaplan-Meier survival curve, more than 70%, and we could do in vivo confocal microscopy to show the stratification. And one of the best proof of epithelium is forming its own basement membrane, which we could show. And genotype, because we took the method that we used was a fingerprinting method, but it contained mixed cells from the center of the cornea, and I was told that it's better to do a single cell rather than group of cells. So what happened was, while doing this, which was very rewarding, we had made an observation which I ignored in the beginning, like many of us do. We were seeing some spindle cells at the bottom of the flask. I did not use the feeder cells, so I shouldn't be having any spindle cells at the bottom of the flask. And there was one group which published that there is a concept of epithelial to mesenchymal transition. And I was not convinced of that. So one of my students made it his PhD topic, and he pursued this work of looking at what are these spindle cells, and two students had to do the work again. In summary, this is the protocol we use to prove what are those spindle cells, because to me they looked like the bone marrow mesenchymal cells which another student was working on. So use the same strategy to identify what kind of, I will not elaborate the details, but suffice it to say the transdifferentiation cornea and the cartilage. And Professor Ratnakar was very fond, and if you remember the anatomy, all these avascular tissues are adjacent to an extremely vascular tissue, whether it is bone to cartilage, heart to cardiac valves, limbus to cornea. Now, how does this nature provide this line of control, or what is we called as a border, and sudden switch to avascularity to vascularity is something I personally don't understand. But there is one interesting, Ambati had published about SFLT being produced. So avascularity of the cornea is now believed not to be a passive phenomena, but a very proactive phenomena. And we could demonstrate that SFLT is produced by the limbal cells, not by the conjunctival cells, not by the oral cells. I am not pursuing this area, but this was a very interesting update. What are the, nothing is perfect in life. What are the problems in this? So we have to have a lab. We have to have a very good procedures. It's a human dependent. I am sure you must be remembering the Reader's Digest cartoon. Life is like that, where one person used to wear a shirt of vertical stripes, horizontal stripes, and the third one would wear a check shirt. And the title said, life is like that. That's exactly what happened. We came as a round circle. We started with using limbal tissues direct transplantation. We went to make a sheet of epithelium and transplanted this. Vrinder combined these two techniques. So we did the explants but in situ. So this was what the procedure, what he called it as SLET, which is done in most cases now, in addition to the cultured cells. So we do not know the role of limbus niche yet, the avascularity, and there are very good reasons. We don't know why the oral mucosa does not help. So this, following the Japanese group, what we did when both eyes were damaged, either we have to take from allogenic, from either parents or some donor. So Japanese group had used oral mucosa because of the similarities to the limbus and corneal epithelium and transplanted. They reported a success of almost 50 to 70%. But what we found is when we take the oral cells bring along with it a vascular bed. It's like a baby carrying its pillow with it. And we did not want this. So in our hands, we only found 30% success, which was not acceptable to us. So therefore, we weaned off from using the oral. Retina, how close? Retina, now we talk about all the different layers. Retina is nothing but an extension of central nervous system with all the multiple layers of the neurons. Our attempts way back in 2002 was to culture the retinal pigment epithelium from cadaveric tissues, and we wanted to look for photoreceptors from the bone marrow stromal cells, which at that time were the favored for transdifferentiation. Others now following this are using induced pluripotent stem cells. So this is one of my colleagues from LVPI, Professor Dr. T.P. Das, who had attempted to use fetal retinal cells to restore the the retinal function. Though there were 1 or 2 lines of improvement in vision, but technically they were, by definition, they were still blind. So where do we get? Because limbus, we had an access to the other eye. We can't touch the retina and we don't know the retinal proliferation because these are the post-mitotic or permanent type of cells in neurons. So in 2000, this was one of the medical students who was doing her fellowship with me. What we took was about human cadaveric cells, and we extracted the retinal pigment epithelium and made explant culture, and we were able to demonstrate sheet of RPE cells using the human cadaveric. But however, these, unlike the limbal cells and the stromal cells, these unlike the limbal stromal cells, these will be HLA-DR positive. So there is only a limited use of RPE, and autologous we can't because these were tested only in cadaveric. The other approach I tried was using the bone marrow cells and made them transdifferentiate into all the lineages that are mentioned in the textbook: adipogenic, osteogenic, neural, and bone-like. We completed all these, including the HLA-DR. But then the developmental biologists argue that all that looks like neurons don't function like neurons. And and this is the looking like neurons, this is the lineage from stem cell to neurons. This lateral entry into neuronal pathway, developmental biologists oppose it. However, we tried. So what are the 2 questions we need to answer? Do they function? And or are they directed by the niche to go and do home there? So I did both types of studies. Electrophysiology, we did both in vitro and in vivo, but we couldn't find the electric impulses that we were supposed to do in this multiple electrode array plate. Homing, we found homing, but there was no ERG. So therefore, we weren't ready for clinical transplantation yet. This is Masayo Takahashi from Riken, from whom I borrowed these cells. Her approach had been, and this is the first human RP transplantation that has been approved, and till the time I met her, they had done about 7 or 8 cases, where from the induced pluripotent stem cells, they had differentiated into RP and transplanted them. And this, again, this work, similar work is being carried out by Dr. Indumati at LVPI. This is not my work, this is to complete the story of development in ophthalmology. using bioreactors and microgravity. Today we are talking about different missiles and space. So way back in 2003, Kamala Datta, who had given some slides to me to share, so they could do the 3D cultures in the NASA bioreactor. So 2D is not enough in neural because they are 10-layered neuroepithelium. So they had used a bioreactor to do this. So this is another promising area, not my area of work. Again, this is from literature, this is from review, where an entire eye has been degenerated. As I said, this is only to share the progress from IPS and ES cells. Another personal, my area is, while doing the limbal work, there was a question posed by International Atomic Energy Agency is, do you have any proposed stem cell therapy for radiation-induced damage? At that time, the only radiation damage I was familiar with the dry eye, and therefore my proposal was we will culture lacrimal gland, and this was again the first human lacrimal gland study which was published in PLOS. So, and what do? Both the lacrimal gland, meibomian gland and conjunctival make a tear film. Those who are into physics or biophysics and biochemistry, I would say this is one of the most unique membranes in the body, the tear film. This has an outer lipid layer, in between is the aqueous layer, and this is a mucin layer which sticks to the eye, and it stands vertically against gravity all the time, as long as you're up. So we tried to culture these human lacrimal gland cells, and this is what we published, which, as I said, was the first human lacrimal gland cultures. So we could grow them, we could make them sheaths. They make this structure not like structures. Can we make duct-like? It's an exocrine gland, it's like salivary gland. Can we make duct-like structures? Yes. Can we make 2D? Yes. Can we make 3D? Yes. Can we make them cry? Yes. So normally if the cells cry, we will start crying, but or we'll ask the students, why are your cells doing this? But here is one celebration where the lacrimal gland cells were cultured and the secretome was evaluated for the tear substances. So we found both the lysozyme, secretory IgA, lactoferrin, which are the most common components of tears, and we found them, and we could make them cry a little more by adding what we call as carbachol stimulation. So therefore, now what do we have out of this lacrimal gland cultures? We have the cellular component, we have the secretome, which could pave way for what is called as the natural tears, and we have now two SERB grants working on this. So these are the spheres. People call them mammospheres, salivary spheres. I call them lacrispheres from lacrimal gland. So this is with another group. This is again, as I said, it's not my work. This is Stephen Schrader, with whom we had submitted an Indo-German project, but it didn't make way. So what they did is they're trying to use the decellularized tissues from the gut or other mucosa, and they are transplanting these cultured lacrimal gland, and both in static and dynamic cultures, and they have published their work, and which shows very promising results. The last part of what I learned, being a pathologist, I was in oncopathology practice for almost 25 years, and cancer has always been very dear to me. And though it's very sad that retinoblastoma, one of the tumors, affects the intraocular tumor in children. So what we now know is normal stem cells is fine, they make this. When this stem cell becomes abnormal, this is what forms a tumor. In fact, the more I learn about stem cells, the more I wonder why all of us don't have tumors. It's not why someone has a tumor. The mechanism is so strong. So anything which goes wrong in this compartment either is repaired or taken care of. It doesn't survive. Those which survive make the tumor cells. So what is the importance of this? And in this tumor, radiotherapy and chemotherapy takes care of most of the cells, but the cancer stem cells will survive, are chemo-resistant, they are radio-resistant, they are like the under-bunker enemy that we talk about. Is it true? Yes, it is true. In patients, in children with post-retinoblastoma, when I looked at the eyes, almost 50% of them had viable cells. Now, why are they surviving and why are they still undifferentiated? And that's led to another journey of mine, that is the cancer stem cells, which we showed in the primary tumors. We showed that it has two population of cells. This particular population of stem cells, that is the FSC low, this FSC, that is a forward scatter low, side scatter low, are the smaller cells with this phenotype are the cancer stem cells, whereas most of them are differentiated pool. Why is it important? If they are chemo-resistant, they are radio-resistant, that's the reason why they are surviving post-chemotherapy. So we had, the approach was both in vitro, in vivo and in situ studies. This led to 2 PhD students' work. So what we can't do all the tests in the primary tissue, so we repeated everything in the Y79 cells. So this is the cytotoxicity assays. While most of the non-stem cells, cancer stem cells will respond to the chemotherapy, the cancer stem cells survive despite being exposed to chemotherapy. And so that's one of the important reasons. We showed both by in vitro, and this is a new animal model that I was talking to you about, and this is the chick embryo in vivo, in ovo experiment, where we generated the tumor nodules with the typical intrinsic vascularity, and we proved that these are the cancer stem cells make more number of tumors, and this is the in vivo testing. Interestingly, those in imaging, most of the imaging equipment have the software to evaluate mice, as I believe. No instrument is ready to evaluate the chick embryo. That's what my NIN, my group, people helped me do this. So this is the cancer stem cells, which shows a lot of metastasis compared to the non-cancer stem cells. So this work was supported by UKRI. Now this chemo-resistant property, can we overcome them? This is with my colleague Anand Kondapi. He gave me a nano formulation of the same drugs. Using the nano formulated drugs, we could show that we could reverse 50% of the chemo resistance in these tumor cells. And that's something that I'm pursuing further with my colleagues. So to summarize my work, we started with basic. We have to go to preclinical, clinical, and then industry. So if I summarize my work, what did we do in limbal? We characterized them, established and cultures, both in vitro, in vivo. We could finish more than 1,000 corneal transplantations. And there is a company which it started with Shankar Netralaya, Reliance, and it is capable of going into industry. What about oral mucosa? No, we couldn't, because though the Japanese group still do it, but I don't know whether it's something we are doing differently or we are not understanding it, but this was done but not preferred. Combined oral and combined limbal and conjunctiva is still done for those patients which are very severe ocular surface burns. 3D cornea we had initiated with May Griffith, where she had one of the very beautiful recombinant collagen into which all the 3 cells could be transferred. I'm not personally part of this, but this has been initiated. And even the limbal stromal cells are being used to treat the corneal scars. Retinal stem cells, the approach to cadaveric cells is good to do the modeling, but it cannot be transplanted because of the allogenic properties. Animal experiments are there, but currently the preferred route is through iPSCs, and Riken group has already done. The group at LVPI led by Indu, Dr. Tipidas and other retinal colleagues is still awaited when they would be ready to do the iPS-derived transplantations. Limbal stromal cells, as I said, it's done, initiated, and it's very good for treating small scars. Cancer stem cells, it's in progress, and if you are in this field, you would know that many of the drugs which are used for cancer stem cells are in phase 2, phase 3 of clinical trials. And my colleagues' nano formulation for different applications, it is there, but we have not yet proceeded with the formulation for retinoblastoma, and it is still awaited. So with that, I would like to thank once again all my students, all my collaborators who helped helped me in this journey. Thank you very much for your patience.
Thank you so much, Geeta. What a long road has been traveled, and I'm sure you will walk the journey even longer and make sure that all those awaited or initiated, you will reach yes to the industry.
Thank you so
Geeta
much.
will be happy to answer a few questions.
Yes, Vicky.
When you compare them with the other like bone marrow derived or the prenatal derived, I mean, is it showing all the phenotypic and genotypic characters, or are they more enriched in VEGF factor?
Okay.
From the limbal what you have demonstrated.
Okay. So I didn't elaborate that, but what we did is we compared the limbal epithelium profile, limbal stromal cell profile, and bone marrow derived stromal cell profile to answer these points. Are they derived from limbal epithelium? No. Are they derived from limbal stroma? Yes. What is the similarity with bone marrow mesenchymal cells? Phenotype, HLA-DR, transdifferentiation potential, gene expression pattern, the secretome, the soluble factor, everything is similar to the about 80 to 90% of similarities. However, we also believe that MSCs, in addition to having the common properties, have tissue specific properties. So we found some about 20% of differences between limbal derived, bone marrow derived, and so on. So whether it is of adipogenic or bone marrow or limbal or any other Wharton's jelly, my personal belief, though I have not worked at not more than 3 types of MSCs, I believe that 80% of similarity is there, which is ubiquitous to all MSCs, but there is 10 to 20% of tissue specific signature in these cells. So that's the reason why I believe that the homing phenomena is something. So in addition to the long distance MSCs coming and rescuing, the local MSC should be able to do it faster if they are intact. So that is my
All the cytokines, like the anti-inflammatory cytokines, what you showed in the last slide.
yes.
Because that will become a very, I mean, for your clinical work, that would be very important, because if it is having more anti-inflammatory factors in your secretome.
Yes, so we did that ELISA of cytokine profiling from the conditioned media and also the gene expression from the cells. So another thing we found was that there is a complementary, I have this slide I can share with you, there is a complementary ligand receptor relationship between the epithelial cells and the stromal cells, just like is believed to be in the bone marrow stem cells and MSCs. So the ligand receptor was exactly the complementary, and the soluble factor, there was one limbal stromal factor was derived, epithelial and there are some factors which are specific in the limbal epithelial cells conditioned media and stromal cell conditioned media. So you're right that the secretome is as important as the cellular component.
And the 3 C's are also very interesting.
3 C's is, I owe it to Professor
Very
Ratnakar,
interesting.
who used to challenge us with the 3C in our pathology residency. So he was very fascinated. And if you remember, and that line of control is so narrow. The moment the cartilage becomes vascular, osteoarthritis sets in.
Exactly,
The
yes.
moment the cartilage becomes vascular, the plasticity is lost and the cardiac valve disease starts. The moment the cornea gets vascularized, the visibility and transparency is lost. So he threw a very challenging question, but I don't think anyone has answered that.
Thank you so much.
Thank you very much. Yes, please.
Macular degeneration.
Yeah, so in ARMD, and the vascularity across the Bruch's membrane. So is the damage first in the photoreceptor or in the RPE in the Bruch's? So first is to identify to pinpoint the damage. Then you talk about the rescue. So in ARMD, if it is the RPE damage, as I said, there are two things which are being done. Auto RPE transplantation by rotation. You go to the periphery of the retina where the RPE is intact and do an auto, like flap, skin flap they do. So auto rotation of RPE transplantation is being done. And by Susan was what she was doing. Then RPE inserts have been introduced. So another progress was photoreceptors. So both there are cellular approaches, non-cellular approaches. The non-cellular approaches of course have been the retinal chip and the bionic eye, what they talk about. But the photoreceptor, there is, other than the RPE or some of the other cells in the retina, IPS is the only favored one as of now to make the entire retina. But then the ethical issues have to be clarified. The problem with IPS is when we go to the court, मैं सच के सिवा कुछ नहीं बोलूँगा type, you know. So can the IPS cells vouch that I will make only RPE and nothing else? I don't think, so that's the challenge what Masai also says, that it's a purity which is a problem. So I haven't done more after the bone marrow attempt through to photoreceptors, but as of now, other than the medical therapy, auto RPE transplantation and the IP derived RPE cells, that is the limited progress that has happened. Thank you very much for your patient listening.
Thank you, Geeta.